So now it gives me the great pleasure and privilege to introduce Dr. George Jallo. Dr. George Jallo is a consultant neurosurgeon, pediatric neurosurgeon at the Johns Hopkins All Children's Hospital in St. Petersburg, Florida. He was the former chair of the department there, but now um, he's now the physician in chief at the department, at the hospital, as well as neurosurgeon there. He's got a wealth of experience and expertise, so it will be great to hear from him on medulloblastoma and the surgical perspective. Thank you, Dr. Jallo.
Thank you, Naren, and good morning, good afternoon to everybody. Hopefully everybody can see that presentation right now.
Yes.
Great. And I just want to, and again, it's wonderful to be able to speak about medulloblastomas here at this Grand Rounds and Multidisciplinary discussion webinar today. I'll skip I have no disclosures and just a little background. I think we heard already about just the incidence of this, as well as some of the origin of these tumors, and typically more commonly seen in children than adults, and has a bimodal distribution. Young children between 3 and 4, and then again between the 8th and 9th year as a presentation. Looking at this, I think when you look at all central nervous system tumors, I think the medulloblastoma is comprises probably one of the largest frequency of malignant tumors in children less than 15 years of age. When you look at all tumors, the embryonal tumors and the medulloblastoma is comprised about almost 2/3 of these tumors. I think we need to go a little back historically with Cushing's description of this entity back in the early 1900s. And looking at his first report was when a pre-adolescent child who complains of headaches, neck discomfort, and begins to have some episodes of emesis without any nausea, usually typically in the morning. The family doctor suspects a GI disorder, but inspects the eye grounds, and lo and behold, there's choke discs or papilledema. And really, if this isn't recognized soon, this clumsiness increases, the vomiting grows, the child begins to become anorectic, lose weight. There's some muscles become wasted, atonic, and then some cranial nerve deficits with the facial palsy, maybe an internal squint that may be bilateral, and then eventually becomes extensor posturing, and the child's bedridden. He described this whole story that if no intervention is performed, this is within the year, highlighting the malignant nature of these tumors. And back then, I think Cushing and Bailey classified these cerebellar tumors arising from the within the posterior fossa and the cerebellum. And he had operated on about 60 such children, and found and called the cell of origin really. I think he called it a medulloblast, which was a misnomer at that time. And you can see that his surgical mortality was 1/3 of the children succumbed to surgery, and that if with a radical operation, the survival was 17 months, and if just a limited biopsy, the survival was much more short-lived at 6 months. Again, recognizing the need for the extent of resection for these tumors. And although this is an old article, I think it's a wonderful article that highlights the historical perspective and the overview on these tumors that was published by Jim Drake, Jim Rucka, and Harold Hoffman from sick kids in Toronto, although, about 20 years old. I think when I look at the timeline with the initial description in the mid 1920s, the 1950s identifying that the radiation therapy improved the survival, the staging, as well as the number of randomized trial. This is another one from the International Brain Tumor Alliance. And I think want to just highlight some of the points of this. Besides the radiation is in the 1990s, the Pediatric Oncology group evaluating the benefits of chemotherapy-only approaches for the young infants and children with these tumors. And then in the early 2000s, the beginning of the genomic analysis of these tumors and the existence of molecular subtypes, as well as I think most recently is the understanding of even further subtypes and the role of maybe reduced radiation and tailored or targeted chemotherapy for these. I think we had a great lecture on imaging, and I think just to briefly highlight a few points. I think, looking at a child with a posterior fossa tumor, looking at the T2 sequences, whether it's hypo-intense or hyper-intense, and then looking at the apparent diffusion content, as well as the variable contrast. I think, it differentiates between a malignant tumor from your low-grade astrocytomas, and then looking at the growth pattern. I think, Rich, we did have a great lecture on radiology, so I'm not going to harbor on this. There's some imaging both on the CT scan as well as MRI for the classic medullos. The other histological classification is your desmoplastic nodular medullo, which tends to be a little more hemispheric and an older population, and then your anaplastic or large cell medulloblastoma that you can see the dissemination as evident here on the sagittal T1 MRI. Again, I think, I will stress that preoperative spinal imaging is mandatory to be able to assess if there's dissemination within the spinal canal, and your leptomeningeal metastases can be what we'll call sugar coating and or nodular, both dorsally or ventral to the spinal cord, and then your metastases down into the cauda equina, as well as leptomeningeal intracranial metastases that can be present both in the subarachnoid space, cisterns, the Sylvian fissure, and or within the ventricle. And I think, when we talk about metastases, there are many theories for this. This could be just you've got the primary tumor in the fourth ventricle posterior fossa. It could be CSF seeding, and or it could be hematogenous spread through the blood vessels back into the back into the neuroaxis. So, I found this slide very helpful, looking at the subtypes on the MR imaging, looking at both the T1, T2 axial and the coronal, looking if it's a midline versus a lateralized origin of the tumor. If it's lateralized and the epicenter is close to the CP, the cerebral-pontine angle, more likely to be the wingless, the wind type, versus the hemispheric type, which might be the sonic hedgehog. If it's in the midline, looking at the sagittal and the coronal sequences, is it reaching the tentorium? That would suggest a sonic hedgehog. If there's peritumoral edema, if that's present, again, may be suggestive of the sonic hedgehog, versus if it's, looking at the absence or the mild uptake on T1, you can see if it's a fluffy appearance, that might be a group 3, patchy, group 4, and the homogeneous enhancement is the wind type. And, I think it's very helpful to understand the precursor cell of origin, whether it's from the lower limbic rim or the upper rhombic limb. Really, it helps in terms of the identification on the imaging studies the location. As you can see here in the Wnt, it's slightly eccentric. Group 3 and 4 are typically midline tumors, given their cell of origin in the subventricular zone of the upper rhombic limb, and the sonic hedgehog arising from the external granular layer. Here's a recent paper that was just published looking at the neurosurgical advances and nuances in medulloblastoma. Came out of Dave Daniels in the Mayo group that looked at the development and the origin of these tumors, and again, further confirming the MR algorithm that I had just shared earlier. So from the surgeon's perspective, I think, the question comes up, what is the best approach? I mean, there's been a lot of controversy. When I was training in the previous century, I will agree that we used to approach all these tumors via transvermian approach, and then we didn't understand, posterior fossa syndrome or cerebellar mutism. With the further research and understanding of this, devastating postoperative entity that occurs with the resection of these tumors in the posterior fossa, there was a movement to go towards the Teeler-Wheeler approach that was advocated both in Pittsburgh as well as from Roten's laboratory. And I think most elect to favor a Teeler-Wheeler approach, given that there's some slight data suggests that there's a less risk for developing posterior fossa syndrome in these children. I will skip the video here that shows the Teeler-Wheeler approach. And again, you can see here from these operative images that this tumor extends out from the fourth ventricle in the midline. And there's been discussion of using the ultrasonic aspirator versus dissection. This is an old video. And then the placement of retractors, or not even the use of retractor or list surgery to try and help prevent the development of posterior fossa syndrome. We've come a long way in terms of the WHO classification. The original in 2007 that focused on the light microscopy, the H&E, and really no classification based on the genetic alterations. And then the 2016, I think, looking at, restructuring these tumors and looking at the molecular parameters. I think when you look at 2007, you had the H&E. It was really the four subtypes, the desmoplastic, the one medulloblastoma with extensive nodularity, anaplastic, or large cell. In 2016, you really had the genetically defined tumors with the Wnt, the sonic hedgehog, group 3, group 4, and as well as the histologically defined tumors. And, here in this histopathology, you can see, the classic medulloblastoma that's in A with small blue cells and some moderate nuclear pleomorphism. In the middle was the large or anaplastic, which had increased nuclear pleomorphism, as well as a increased mitotic rate. And then the third one on the right is the desmoplastic that demonstrates nodules with some variable nuclear pleomorphism. I think, the 2021 molecular classification brings them all together with the H&E, the molecular genetics, as well as the identification of these tumors. And you can see that the integrated approach of the medulloblastoma, the Wnt, the sonic hedgehog, and then your group 3 and group 4, as well as the histological and the prognosis there. And I think, when we account for all these, the Wnt type accounts for about 10% of all medullos. The sonic hedgehog is about a third, And then your group 3 and 4, I will say is about another third each. So when we look at this, and then in terms of the distribution amongst children, your WNT is really typically your older children. Your younger children are more likely to have your sonic hedgehog or your group 3 tumor, and then your group 4 can affect children of all ages. And I think this slide here shares all the major 4 subgroupings: the age, the anatomic location, the histology, the percentage of metastases, as well as the prognosis and the molecular characteristics of these tumors with the gene mutations, as well as the amplifications associated with these tumors. So I think I think this algorithm now, really, if you've got a posterior fossa embryonal tumor, you've got to rule out the other entities. Once the medulla is determined, you look at the histology, look at the genetic signature, and then once you've got that integrated diagnosis, I really do believe one can make the best recommendations for treatment. And you can see here that based upon these subtypes and the risk adjusters for whether it's MIC or MB altered, amplified, the prognosis, whether it's going to be favorable or a standard prognosis or a high risk prognosis. And this further defines the medulloblastomas, the staging, the therapy that depending upon whether it's an average risk, depending upon the traditional extent of resection, and Chiang's classification, if there's dissemination, whether one will use conventional chemotherapy and or modified or targeted therapy that we can discuss in the next presentation. And I think, looking at all this, it really does help. It makes these groups not just, it's a medulloblastoma, but really having the true understanding of these helps determine the overall prognosis as well as the best treatment. So, I think just to summarize the treatment, looking at this, you've got the surgical resection, the histological diagnosis is a standard risk depending upon the age, the extent of resection, and the presence or absence of dissemination versus a high risk, and or is it going to be radiation and conventional or therapy, depending upon the molecular subgrouping, to use some targeted therapy and or novel agents, and the overall prognosis for these particular tumors. So the question comes up from the surgical perspective is, how do you manage the preoperative hydrocephalus and CSF diversion? I think many really depends at the center that you're at. Some groups advocate for a placement of if a child presents with a posterior fossa tumor and symptoms of obstructive hydrocephalus, centers will advocate for either placing a VP shunt prior to the planned surgery. Others will place an EVD, and a ventriculostomy catheters, and others would advocate doing an ETV, an endoscopic third ventriculostomy, prior to the resection of the tumor, and felt that doing the ETV, the need for a permanent VP shunt was almost was almost cut in half for the need of a permanent VP shunt. And then there's others that what are the indications for the ventriculostomy catheter. And in my mind, I think placement of ventriculostomy catheter for these tumors is if a child presents with symptomatic hydrocephalus, we advocate for an EVD prior to surgery, or even prior to the imaging studies. As most recently, we had a young child that presented with a posterior fossa tumor, some vomiting, and some just sleepiness. The CT showed the fourth ventricle tumor and significant hydrocephalus. So we elected to place the EVD before obtaining the MR imaging, and knowing that it would require us to sedate that young child to be able to complete the MR sequences. So, and then at time of surgery, we maintain the EVD and then wean it during in the postoperative period to see if they will require a permanent diversion or just being able to remove that drain. So the other condition is really cerebellar mutism. It is depending upon the reports, anywhere between 20 to 30% of all children that undergo any posterior fossa surgery for a tumor, regardless if it's a medullo, are at risk to develop cerebellar mutism or posterior fossa syndrome. And it's a triad of that decreased speech, mutism, an element of cerebellar dysfunction, as well as some neurobehavioral symptoms with irritability, apathy. They can also have some, depending upon the degree of this syndrome, they could develop some bulbar apraxia, incontinence, require feeding tube given their inability to swallow. And there are many theories on this. Is it traction or is it injury to the dentate nuclei, the vermis, and or the cerebellar hemispheres? I think we like to say that most patients recover somewhere around 2 to 3 months, but they do require rehabilitation. And recent studies have shown that although they do recover, they may not return to the baseline, their preoperative baseline. And then, regarding the TLR-VLR or a transvermian approach has been discussed. This recent paper in Children last year looked at the syndrome and reviewed what the many parameters in terms of what may predict the development, whether there's brainstem invasion, the location to the midline, the size of the tumor, the invasion of the superior cerebellar peduncle, the handedness of the child, whether it's a transvermian or versus a TLR-VLR approach, and then the histological diagnosis of the tumor, medulloblastoma versus other tumors. And again, some of the major findings was that it was really an interruption of the dentothalamo-cortical tract, and that and or direct cerebellar injury is really an reason for some of the persistent mutism following the development of this. Other findings were the use of a TLR-VLR versus a transvermian approach, as well as avoidance of the CUSA and prolonged retraction during surgery, all were were statistically significant in the development of this. And then this paper that was just published looked at the outcomes, the emotional behavioral outcomes following the development of this, and they looked at 45 children, 30 which did not develop cerebellar mutism, 15 that did. And what they found was that the children that had cerebellar mutism, as compared to the ones that did not, had significant deficits in adaptive function and practical skills years after treatment. And it goes on. It really refutes the hypothesis that cerebellar mutism or cerebellar posterior fossa syndrome recovers in several months' time. So I think at the end of the day, when we look at this, we're still not really sure what happens, but advocate for working quickly and efficiently, try to avoid a fixed retraction, and be careful on the dentate nuclei as well as the cerebellar peduncle. And then, as I begin to close, I do want to highlight that, that although rare, medulloblastomas can occur in the adult population, and this is a single study that looked at 76 adults who were predominantly male with the median age of around 30, 31, who had the diagnosis of medulloblastoma. And of their series, the majority, close to almost 50%, were the sonic hedgehog activated, and only about 7 or 8% were the Wnt variant. The others, the remaining, were similar, were the mixed in the other groups, and that close to 2/3 did undergo gross total resection, and almost 98% of their population did receive radiation and chemotherapy. And you can see, both the histological diagnosis as well as the molecular subgrouping. So I think, as we begin, it's probably, as we begin to summarize, I think looking at these subtypes, I think when you look at the Wnt group, I think this is the one group that we can begin to discuss minimizing radiation and chemotherapy and try to look at new treatment groups. I think the sonic hedgehog is a little more complex for treatment. They're less vascular and harder to get desired levels of therapies. And I think, looking at the presence of the DP53, as it may portend to a worse prognosis in this group. Group 3s have a dismal or horrible prognosis, of which more than half have are metastatic at time of presentation, and that the older children may have a 50% survival, whereas the younger children have just a dismal prognosis. And then your group 4, your glutamatergic subgroup, which is common, one of the more common ones, predominance in male, and really may have some excellent, although the average risk groups may have some excellent survival, but some of these group 4s with the chromosomal aberrations and may present with metastases, have a horrible prognosis. So Naren, thank you for listening to me this morning or this afternoon, and I'll be available for any questions at this time.
Thank you very much, Dr. Jallo, for that excellent lecture covering all aspects from history to current management and the controversies of the related secondary conditions. First of all, going to go to Mr. Ajay Sinha. Mr. Sinha, your comments on the lecture and your questions, please. Thanks.
Oh, excellent talk, George. You covered practically every aspect which needed to be covered for the trainees. Just a couple of comments. I mean, one of the few things which has not been very well illustrated in cerebral mutism is age. I mean, most of the cases where you get cerebral mutism tend to be under 10. Children who are older seldom get into cerebral mutism problems. And other aspect, whether you do a transvermian or a transtelovelar approach, it's a tumor's location and determines whether you can just stick to a telovelar or you need to extend the incision. I think the tumor decides which approach you need to take, or you could just stick to just a telovelar. And I'm not hung up on that. Any approach where they have minimum cerebellar retraction is what I tend to prefer. At any given time, I don't use more than one retractor and try now use the minimum amount of fixed retractors. I'm still very partial to CUSA, and I'll still stick to that. And I don't think it has made a huge difference to my outcome. And that's all I have to say.
No, thank you for sharing your experience, and I do agree with you. I mean, if you're gonna, you can't fix on a telar velar rather than a transvermian approach, especially if the tumor's high up in the fourth ventricle. You're going to do the telar velar, and then you're going to retract the hell out of that cerebellum and the nuclei. So maybe opening up the vermis a little and putting in less retractors is probably a wiser choice. So I agree with you on that. I think the key is avoiding multiple retractors. I've seen early on in my training, we my mentors would place 3 retractors, one on each side and one on the top, and give you the entire visualization of the tumor and try to achieve an en bloc resection. That can't happen. You can't do that. That's where you will run into the postoperative complications. So I agree with you. I think, one retractor is reasonable. And if you're not working on that side, just move it, remove it, and work efficiently. The other is, I think there's been, discussion about the treatment of hydrocephalus, putting it in a Meyer reservoir and tapping. I'm not a believer in placing reservoirs. I think you're either I prefer ventriculostomies. I am not a fan of endoscopic third ventriculostomies before surgery. The goal is, if you remove the tumor, the pathway should open up. If you need to treat the obstructive hydrocephalus, I think EVD is probably the best approach. And then one can manage the need for a VP shunt, or even consider an ETV following surgery in the recovery period. And in my experience, I'd say, the literature says about 20-30% of patients will require some form of CSF diversion. In my experience, it's much less. I think it's closer. It's more on the order of like 10% of children with a posterior fossa tumor, all comers, whether it's a polycytic, ependymoma, or medullo, or even ATRT, will require a permanent CSF diversion.
I agree. I think I've totally moved away from ETVs in the preoperative ETVs for medullos, or for the most posterior fossa tumors, to be honest, because you having an external ventricular drain makes your surgery much easier. And in the post-op, the wound healing, CSF leaks, infection, they're all minimized, and then you have time to challenge it. You run the risk of post-op infection, CSF infection, but that's overstated. I don't think, with good care of external ventricular drains, that should not be a major problem, and we get away with most of the cases. Certainly using regular EVDs rather than doing ETVs, which invariably would block in the post-op period, has reduced the wound complication rate in a big way.
Totally agree. Thank you.
I think one of the things I used to have mentioned to George before in the previous webinars is that I have not done ETVs for posterior fossa tumors, but when they are done, usually the floors, the ones that I have seen anyway, the floors are pretty thick, and I didn't feel comfortable watching them myself. So I think and I agree with you that if you want to do something, EVD is probably safer and easier to do. I just want to go back to Dr. Mukherji on the mutism. I haven't seen much on the literature on mutism and radiological findings. Have you come across anything on, because the mutism suddenly seem to end up being neurosurgical, but has neuroradiologists in your experience have looked at any radiological changes that's more corresponding to mutism? Dr. Mukherji, thanks.
Not that I'm aware of, but depending on the resection, especially if they're midline, I would think it'd be a little bit challenging to correlate the extent of the resection, since a lot of the vermis is removed, with actually the development of the mutism. But that's something that I'll have to investigate. I'm just not aware of it. When I go back on mute, I'll start doing a Google search and see what I can find.
Please, thank you. Because the other thing about the mutism is that, you know, we usually say 20–30%, but, you know, in my, you know, limited experience compared to Dr. Jallo and Mr. Sinha, the mutism is much more extensive and than, you know, what we usually say. And the post-operative ward down, we often say to the parents, it will all get better, but you know, sometimes doesn't get better. But you know, the ones that I have seen, and they're pretty devastating, and it's, you know, obviously it's less devastating than the tumor, but it's sometimes, I mean, I think as surgeons we sometimes look less because we don't usually have the patients for long. Then they move to a rehab ward or somewhere, and we don't. And when they come to the review, then you know they are usually quiet, and we kind of like quiet people, and we talk to the parents and move on. Do you think that the we underestimate how much mutism is actual incident, George?
You know, Naren, I agree with you. I think some of these children have, it's a spectrum. I think some may have an element of you know, sparse speech that we don't even classify as classic cerebellar mutism, where they're, you know, completely mute. But I can tell you, you know, there's some children that we've not classified into this category, but they had a paucity of speech, and they had some scanning speech. So they did, you know, by all amounts, I would consider, you know, you should classify it. We just don't, because they're, you know, they're in rehab, and those are the ones that I think do recover. I think the ones that have the triad, the profound triad of not, you know, being completely mute, you know, being irritable, and requiring a feeding tube, those are the children that, you know, even years later, I don't think ever fully recover back to their baseline.
Thank you.
Agree more. It's a permanent neurological deficit.
Yeah.
It's something which gets better, but doesn't recover back to 100% back to normal.
Correct.
I think one of the things is that when I have had patients who had, you know, motor speech strokes or something, but they are usually cheerful, you know, but the problem with these children are they are very withdrawn. I think the magnitude of the mutism in terms of speech to psychological, and it's a bit more difficult doing neuropsychology on these children. So that's my feeling. Would you say that the other neuropsychologists involved enough in these in this mutism, George, in your unit and in Liverpool?
You know, I will say from in our unit, we try to get neuropsychological testing on all children before surgery. And we connect them so that at least they're followed with our neuropsychologist following surgery, and get assessments and advocates for the best treatment possible if they do sustain any neurological, whether it be mutism or any other deficit.
Thanks. And in Liverpool, Mr. Sinha?
I think get into transition to the head injury in the same pattern, the HERT team, as we call it. You know, run by neurologists, which have neuropsychologists and physiotherapists and all the allied specialties looking after these children. The problem is, you know, the treatment is not as aggressive, because most of the children really go on to have chemotherapy and then go on to have radiation. So they're kind of shifting between neurology wards and oncology wards and oncology care. So it becomes slightly disjointed, but that's the nature of the game. You don't have time. You have to start adjuvant therapy ASAP. So, but you know, as soon as the neurosurgical problem is over, they get transferred straight to the neuro rehab team and to the oncology side, where they, you know, they work very closely with each other.
Thank you. Can I bring Dr. Hesham Elhalawani, Dr. Hesham?
Thank you. And Dr. Jallo, thank you so much for an excellent talk. I really love the historical overview. That was very educational. And I just wanted to echo Mr. Sinha's point on like the importance, even with mutism and posterior fossa syndrome, the importance of starting radiation planning and treatment as soon as possible and not delaying, even in kids with significant posterior fossa syndrome. To my understanding, like this has been like the consensus recommendation, since it wasn't found that radiation can significantly delay the recovery process, and the risk-benefit assessment was overwhelmingly in favor of not delaying radiation. I guess my question for our fellow neurosurgeons is there anything that you would do differently for kids receiving radiation who have a posterior fossa syndrome? And specifically the question of that it's not uncommon for us as radiation oncologists to prescribe low-dose dexamethasone for like increased cerebral edema and increased intracranial pressure because of radiation. But how would that interact like in a negative way for kids with cerebellar mutism who have some neurobehavioral manifestations?
Do you want to go first, Jude?
Yeah, no, I think those are excellent questions. No, I think as much as there is a neurological deficit, I think it's critical to begin therapy. So we don't advocate for delaying adjuvant chemo radiation therapy until that child recovers, because we're not sure when that's going to happen. I think there's lots of theories on this. Does decadron, depending upon the paper that you read, some advocate for steroids, others say that the steroids may potentiate or delay the recovery. I am a believer in steroids, and I don't think I've seen much benefit of stopping the steroids and making their recovery faster. There's some other medications that some believe in to help with this mutism, although I still think it's all voodoo personally. So summary is standard of care.
That's right. There is, I couldn't agree more. It's about voodoo magic, trying out medications to help it. It doesn't work. It's natural recovery.
Thank you.
I'll come back to both of you in a second, but because Dr. Finch probably sees most of the patients in neuro-oncology that we have sent them to with mutism. Dr. Finch, any thoughts in terms of mutism that you see, whether with radiation therapy, whether with your chemotherapy, whether you see it worsened or it doesn't really make any difference? Thanks.
I don't personally think it makes much difference, even when we have the younger kids who get chemotherapy up front. I think with time, most of the cases will get better. So I wouldn't recommend delaying chemotherapy. I don't really have a control group to say that if we did delay and didn't do treatment, that they would get better faster. But I don't think anybody is willing to take the risk.
Thanks. Thank you. Dr. Jallo, two questions. From the day that from the beginning of your career to now, do you have anything anecdotal that you think that you have done that has improved the mutism, or do you think it's still a bit random? And the other thing is, is there any insight or intuition that you have why it actually is, comes in, it takes a bit of time, a few days before it's actually at its full force? Thanks.
No, I think great question, Naren. In my experience, I think it's the retractors, honestly. I trained, we would put 2-3 retractors. Now, I may use one and no more than one on one side or the other. And it's not really a retractor. It's really, I might place it there with minimal to no retraction. It's just so when I'm under the microscope, I don't injure something as I'm going in. So I truly believe it's a retraction of the dentate or the dentothalamo-nuclear tract personally. The other is where I've seen it occur. Is really the ones that are really stuck on the lateral walls of, inside the fourth ventricle. That's where the kids that have developed it are the ones that if I'm having difficulties trying to separate it from the cerebellum, from the vermis and stuff, that's where I predict I'm going to have. The other that I've seen, honestly, a pearl is if during the resection, if there's any blood pressure changes, if there's some episodes of hypertension, that's gonna suggest that you're probably going to develop cerebellar mutism. And that, again, that suggests that, you know, there's you're doing a lot of work on the brainstem area there. And I agree with you. It's interesting. You know, it does develop several days. It could develop. I've seen some children wake up with it. I've seen other develop at 48 to 72 hours. And I can't tell you, if you develop it early, you're going to recover faster. That versus if you develop it later. I think what it is the degree. If it's very mild, just some scanning speech, I think you're going to recover. If it's all the complete triad, you're going to recover, but there's going to be sequela from that.
Thanks. If it was retraction, would you not expect it to be at its maximum just after the operation, and if anything, get better?
No, because, you know, as you know, I think it's an injury, and it may peak at 72 hours, right? So that's where I don't think it's just, you know, you're going to see it immediate from the traction.
Thanks, thank you. Mr. Sinha, do you have any intuition over your career, whether anything that you did has decreased it?
See, the biggest factor is luck and patient's age. I mean, you do the same with every patient. You try and minimize retraction, use the QSA sparingly, and, you know, when you reach the brainstem, always leave a patty on the brainstem, work around the patty so that you don't put any direct pressure on the brainstem. Once you open up the you know, aqueduct and you clear that area, generally I tend to find a bit of tumor stuck where the upper end of the brainstem, where it kind of merges into the aqueduct, and the aqueduct generally tends to be dilated. You have to be very careful at that point. It's just, you know, the tracts are dentato, ponto, rubro, thalamo, cortical. That's the tract. Those definitely goes through the pons. Whether there is any injury when you're directly manipulating and remove the tumor from not only from the cerebellum but also from the brainstem, and you started getting, as George mentioned, vasomotor changes, then you know you're getting into trouble.
Thanks, thank you. Dr. Jallo, in terms of, you know, when you are doing the operation, in terms of avoiding seedlings into the CSF, is there anything that you do, or that's not I mean, you get a seedling of medulloblastoma without operation, but you would expect seedlings to be after, but do you think the chemotherapy usually takes care of that?
You know, I think there's always cells that are spilled during the resection of these tumors. I mean, you know, we don't have nets. Ideally, you'd put a net down there that's going to capture it going down into the you know, the lumbar cisterns, and then plug the aqueduct. But you can't. We don't do that. So I think, you know, we just try to ensure that there's no gross, you know, tumor that's falling down and circulating into the CSF space. That's all.
Thanks. One of the problems is the patients with a pseudomeningocele, and it's and how do you manage patients with pseudomeningocele? And if you do put shunts, is there any particular valve that you put in patients with pseudomeningoceles?
You know, I just for me, children that have asymptomatic pseudomeningoceles that aren't leaking, I just give them time and let them declare themselves. I may consider Diamox. I typically don't cap them. I don't wrap them. I just give the luxury of time to see if it's going to declare itself as hydrocephalus or not.
And if you do put shunts, when there's a pseudomeningocele, what valve would you use?
That's great. I am a believer in a programmable valve. I would tend to favor the Certus, and the reason for that is my goal is, after placing the shunt, is to titrate, you know, treat the pseudomeningocele at, you know, whatever setting it needs to, and then titrate it all the way up, and eventually, you know, do that virtual off to really see if they need a shunt for their entire life.
Any comments from Mr. Sinha in your practice? Any different from Mr.?
No, I use programmer, but I tend to prefer the Methca valve just because we
Yeah.
have a bit more experience with it. But for younger children under 3, I would use the Codman-Hakim programmable.
Mhm.
That's the only one group I tend to use, the Codman-Hakim, because it's very low profile. And some of the children have very thin scalp tissue. If you put in a Methca valve, which is quite bulky, they tend to have problems with wound healing, and the shunt valve may make its way through the skin. So for children under 3, I tend to use the Codman-Hakim low profile valve. For older children, I tend to use the Methca, but there is not much gain by changing from one programmable for the less, in my opinion. It's what works in your hands and what you're more familiar with programming after surgery. Because it's not putting in the valve alone, that's where the story ends. It's how you're going to see the patient, and your nurse is comfortable with programming them and seeing them before and after, MRI scans. The advantage of CHERTUS is you don't have to program it after MRI scans, but others may need reprogramming or at least rechecking. So those things have to be factored in.
Thanks. Just to mention that Dr. Sat Krishnamurthy, who has given talks on CSF protein, one of the things that he would, if he was here, I would think that he would say is that when after operation, the CSF protein content will be higher, and that will kind of draw in CSF fluid from the brain and cause hydrocephalus. And he's nowadays trying to, even in patients with the neonatal hydrocephalus after ICH, he's tending to put, he's doing a study where he's putting Ommaya reservoir and tapping the CSF for a very long time, because his hypothesis that once the protein level goes down, the ventricular size will go down, just for the thoughts. In terms of Dr. Finch, do you have any questions for Dr. Jallo, please?
I don't personally, but there is a question in the chat,
That's
and
right.
I'm curious actually what this CUSA is.
Oh, this is
I think it's the Cavitron. It's an ultrasonic aspirator. I think I showed a picture of it. I don't know. Again, it's what the literature. I've used the ultrasonic aspirator, and I can't say that I've had an increased number of children with posterior fossa syndrome when I use it. I now do avoid it. I could see the theory of, the thermal injury, heat that it may cause during during the removal that may lead to damage of the, the dentothalamo, the tracts or the nuclei there. But I don't have, again, there's no solid paper to say why it doesn't work. There's papers that say you should use it, other papers that say you shouldn't.
Thanks. The CUSAs can get pretty hot at the at their tips, the ultrasonic aspirators, but I don't think, as you said, there's much on that. Dr. Mukherji, can I bring you back, Dr. Mukherji? Any questions for Dr. Jallo and any comments that you have?
And Dr. Mukherji, thanks for sharing that paper. Those are the papers I referenced in the talk that show it. The group in DC Children's is the one that doesn't believe in the CUSA personally, whereas others say there's no effect, but the literature supports to try to avoid it. But here's for your thoughts.
Sure. No, I wasn't familiar with that, but there is some information in the literature suggesting that there's abnormal signal in the bilateral dentate nuclei, the superior cerebellar peduncle, the middle cerebellar peduncles. It's still theoretical. Some people, it could be due to the schisis form when you separate the cerebellar hemispheres as well too. Everything that I've kind of listed on said it could be transient vasospasm during the surgery. And some of the edema that you see in the superior cerebellar peduncles may be associated with high DWI signal as opposed to low DWI signal, which would infer an infarct. So the high DWI signal just more suggests transient edema, and that may be why you have the transient cerebellar mutism. So those seem to be the imaging findings associated with it. I did want to ask you though, you had a beautiful diagram actually demonstrating the origin of the specific types of cells that eventually went on for Sonic Hedgehog or Winglet, etc. Were those your illustrations, or was that from the literature somewhere? Because I thought that was a
Nope.
beautiful demonstration.
It's from the literature. I'll share that with you and the group as soon as I find it.
Yeah, that was lovely. Thanks for sharing that.
Thank you. Thank you, Dr. Mukherji. In terms of the residue and 1.5 centimeters cube, and there's a controversy whether it matters or not. What's your institutional policy in all children's? Do you guys go back if it is more than 1.5 centimeters or on the post-op scan?
You know, it's interesting. Yes, you know, we again, it's at 1.5 centimeters squared. You know, for us, we will go back as long as it's not disseminated. You know, our oncologists push us to, although I think we need to, you know, that was a paper published in the 80s and early 90s. I think from if I recall, I think it was a Pittsburgh group. I think we should throw that paper out with our understanding of these subgroups now, because, I got to tell you, Naren, I remember when I was up in Baltimore, I had a small residual that was, about 1.5 centimeters squared. The kid did, after the first resection, did great. But the oncologist said, "Oh, we've got to go back." And I was more like, there's probably a reason why I left that there. And I wasn't, didn't feel comfortable going after it. But after, our multidisciplinary conference, everyone's like, go back, go back. I went back, and the child that had no deficit after the first operation, I got the complete resection, made it look good. I gave him a cranial nerve. I gave him a facial palsy. And, to this day, it's a lesson learned that, do we really need to go back for those small residuals? I think for certain subgroups, yeah, I think so. But for tumors that are disseminated, I don't think there is a role to rush back into surgery. Use adjuvant therapy. And, if you want to do a second look down the road, I think that's reasonable.
Thank you. Thank you very much, Dr. Hesham Elhalawani. And do you have any questions for Dr. Jallo?
No, not really. I'm all ears. Like, that was very interesting and I learned a lot. Thank you.
Good, thanks. Dr. Chiang, and then Mr. Sinha, thanks.
Yeah, I think that's an excellent talk. I enjoy the historic aspect of the medulloblastoma, and also the slides showing the cell of origin. That correlates very well with what we see on histopathology and also on the MR images. And before reaching the pathologic diagnosis, I like to pick the MRI, as I earlier mentioned. So that is very useful practically from my perspective. Just two things to add. One is for the wound medulloblastoma, I think people usually assume wound medulloblastomas have good prognosis, but since we see probably 400, 500 medulloblastoma a year, we do see a rare variant of wound medulloblastoma that has melanocytic or myogenic differentiation, and they don't do well. They are pretty aggressive. They disseminate early and they kill the patient. And they are not in the WHO, and the only way to tell them is by histopathology. So just something to keep in mind. If you see an aggressive wound medullo, that's probably what it is. And the other thing I want to add is for the infant hedgehog medulloblastoma, now we know they separate into two molecular subgroups, and that correlates with and they oftentimes show the same desmoplastic nodular histology, and sometimes we associate desmoplastic nodular histology with good outcome, but the DNA methylation should be done for the infant medullos so we can know the subtype of them, and which is associated with prognosis and probably the following therapy. We have a trial for infant medullo, and An additional thing about infant-medullary is since we have the infant-medullary trial, we screen a lot of infant medulloblastomas. But the interesting is that most of the infant medulloblastomas are not actually medulloblastomas. So just to keep in mind that don't assume every posterior fossa medulloblastoma is a medulloblastoma. Again, that was an excellent lecture from Dr. Jallo. Thank you very much.
Thank you, Jason. Anything, George, to
No, that was all. No, absolutely. I will share that paper shortly about the or cell of origin and tumor location on imaging.
That's great, thanks.
Then will you share it to us, please, the paper from George?
Certainly.
Mr.
And
Sinha,
just to add to what Dr. Jallo said about, leaving behind a certain amount of residual tumor. I mean, that study was based on CT scans, not MRI scans of 1.5 centimeter cube of tumor being left behind. And I suspect, there was a lot of surgeries done and aggressive surgeries done just because people were so worried about being criticized in tumor board meetings. And I suspect quite a few patients did suffer because of that, the incidence of perhaps, neurological deficits, mutism did go up just because of fear of leaving behind residue.
I remember when I was a resident, my attending taking back a patient very reluctantly because it was just above 1.5